Welcome to Pharmacology lectures. Now we are going to start ANS, autonomic nervous system. We'll have a look at its anatomy. Now, nervous system is divided into two parts. One is peripheral nervous system and the other is central. This is about the peripheries, about our limbs and all, and central is about our brain, spinal cord. Now, in our peripheral nervous system, there are two types, efferent and afferent. In efferent, where we receive signals, it is autonomic system, and the other is somatic, directly into the muscles. Okay, autonomic system, this we are going to study in detail, and this has major effect on our body, and the drugs are also very, very important. In autonomic nervous system, it is divided into three: enteric nervous system, parasympathetic nervous system, and sympathetic nervous system. Now we'll have a look at the functional division, a little bit of anatomy. We'll have a better look here. Now there are two: a preganglionic neuron and postganglionic neuron. This is the ganglionic part, like this. This is the ganglionic part, this is presynaptic, and this is postsynaptic. Now, preganglionic neuron, the cell body is in the brainstem or the spinal cord. This is the ganglionic transmitter, releases the transmitter, activates the postganglionic neuron, and this postganglionic neuron, it transfers to the effector, where we need our effector organ. Now this is a very, very important diagram. Sympathetic division, parasympathetic division, and these are the effectors. Now this is cranial nerves. These are cranial nerves: cervical, thoracic, lumbar region, and sacral region. Now thoracic region mainly regulates sympathetic chain for our eyes, salivary glands, then lungs, heart, liver. Our lumbar region regulates bladder, kidneys, reproductive organs, and similar for both. The regions are same. Now the effect is different, opposite. Sympathetic and parasympathetic both have opposite effects. Now this is the ganglion. This is preganglion in the brain or in the spinal cord. Okay, and these are the effector, and these are all ganglions. A little bit of anatomy has been shown here. This part is preganglionic part, and this is the ganglion, the middle portion, and these with the effector organs are the postganglionic region. Now functions of sympathetic nervous system and parasympathetic, both are given here in red and blue. Sympathetic is red, we also call it fight and flight system, whereas parasympathetic is when you calm down, and that's why it is shown in blue color, parasympathetic actions. Eye, what happens when the sympathetic nervous system is activated? Iris radial is contract, pupil dilates. Just you have to remember pupil dilation. And when the parasympathetic is activated, the opposite happens, pupil contracts. Trachea and bronchioles, sympathetic dilation, parasympathetic constriction. Adrenal medulla, secretion of epinephrine. Kidney, secretion of renin, ureter, and bladder, relaxation in sympathetic, and parasympathetic contraction. And ejaculation in sympathetic and erection in parasympathetic. Lacrimal gland, stimulation of tears in parasympathetic. Thick secretions in sympathetic. Increased rate in sympathetic and decreased rate in parasympathetic. Decreased motility in sympathetic and increased muscle motility in parasympathetic. Relaxation of the uterus in sympathetic, dilation of blood vessels in sympathetic, and constriction of blood vessels in sympathetic as well. Now, effective stimulation of sympathetic system is also known as fight or flight response. We'll just have a look here, fight or flight response, because the direct sympathetic activations by stimulation of the adrenal medulla, which releases epinephrine or norepinephrine and hormones released by adrenal medulla directly enter the blood and promote all the responses in the affected organs. Agonist. Now these are the name of the drugs we have to study, and we will see them in detail. Direct acting, those drugs which will act directly, they are acetylcholine, methanicol, carbachol, sevimicline, methacholine, nicotine, pilocarpine. Indirect acting are also known as reversible: donepezil, androphonium, galantamine, neostigmine, physostigmine, pyridostigmine, rivastigmine. Indirect acting but irreversible: ecothiopate, reactivation of acetylcholinesterase, pralidoxine. Now these are cholinergic agonists. Agonist means they will mimic the action of cholinergic system. Now we have seen this before. The preganglionic fibers terminating in the adrenal medulla, the autonomic ganglia, both parasympathetic as well as sympathetic, and the postganglionic fibers of parasympathetic division, they all use acetylcholine as a neurotransmitter. Here the postganglionic sympathetic division of sweat glands also uses acetylcholine. In addition, cholinergic neurons innervate the muscles of the somatic system and play an important function in the CNS. Now, neurotransmission, or the mechanism of action of cholinergic neurons. Neurotransmission in cholinergic neurons involves 6 sequential steps. Now, the first one is synthesis of acetylcholine. How does it occurs? We'll have a deep look. First is synthesis choline acetyl transferase, that is an enzyme. This choline acetyl transferase catalyzes the synthesis of acetylcholine from choline and acetyl CoA. Choline and sodium, they enters the cell. Choline and acetyl CoA, they both are converted into acetylcholine with the help of acetyl transferase enzyme. Now once the acetylcholine is formed, what will happen? It is taken into the storage vesicles. Acetylcholine is protected from degradation. Once it has been taken in the vesicle, it will be protected. Third, now it should be released in the ganglionic region. Release of neurotransmitter, it is release is blocked by botulinum toxin. This toxin blocks the release. Okay. Spider venom causes the release of acetylcholine. These two are some important points. This toxin will block, and this toxin, venom, it causes excessive release. Okay. These two effect on the release system. Fourth is binding to the receptor. Now once it is released from the vesicles, then it binds to the receptor, postsynaptic receptor. Okay, and once it binds, it will activate the receptor complex. Now after fourth, the fifth part is once it is activated, the chain reactions occur, then it has to be degradation of acetylcholine. Degradation is acetylcholine is rapidly hydrolyzed by, again, which enzyme? Acetylcholinesterase enzyme in the synaptic cleft here. Once it is degraded, choline is released, choline is then reuptaken, and again acetylcholine is formed, protected in the vesicle, released. Some of them will form receptor complex and some of them will again degrade, and the cycle continues. Okay, we have seen these all 6 pathways. Now this will study cholinergic receptors, cholineceptors. Okay, we'll study in the next. To have a look at direct acting cholinergic agonist. Those which act directly and are cholinergic agonists, they will copy the same actions. When acetylcholine binds to cholineceptors that are muscarinic or nicotinic, these agents are broadly classified into 2, which are directly acting. There are 2 types: cholineesters or naturally occurring alkaloids. Cholineesters are acetylcholine, synthetic esters of choline such as carbachol, bithanicol, and the other naturally occurring are nicotine and pilocarpine. All direct acting will have longer duration of action, and these 2 basically, for the first one it is bithanicol, the important drug, and the second it is pilocarpine, which we have to study and remember it. Okay, preferentially bind to the muscarinic receptors and are sometimes known as muscarinic agents. Okay, you can have a look at the structure. It is very important to see the structure. It usually comes in your licensing exams. Acetylcholine first. There is a chain, there is an amine group, okay, and there is also bond cleaved by acetyl. Okay, usually here acetylcholinesterase works and it separates them both. Now, what is the difference between acetylcholine and bithanicol? The bithanicol is a derivative. What happens? Only one methyl group has been added here in this C carbon, and one amine group has been added instead of methyl group. For acetylcholine, there is no branching over this C and methyl group is present, and for bithanicol there is a branching over this carbon and an amine group is present at the end. Now, for carbachol, there is no branching but an amine group is present here. Pilocarpine is a natural product, and you can see here there are 2 rings for pilocarpine. Ethyl group and methyl groups are here. Now, first we are going to study deep about acetylcholine. Now, acetylcholine is a quaternary ammonium. Okay, we have seen it has an ammonia compound, quaternary. It has 4 carbons that cannot penetrate the membranes because it is a large structure. Now, what actions does it show? Decrease in the heart rate, decrease in the blood pressure, and other actions we will see. Now, how it decreases the cardiac output. Acetylcholine decreases cardiac rate, that is bradycardia, and cardiac output because reduction in the rate of firing of SA node. Decrease in BP. Acetylcholine will activate M3. We have seen previously M3 receptors found on the endothelial cells lining, or for heart there was M3 receptor of the smooth muscles of blood vessels. This will result in the production of nitric oxide and arginine. Nitric oxide will then diffuse into the muscle cells and it will stimulate protein production, and then hyperpolarization will occur, smooth muscle relaxation will occur. So, as in the absence of cholinergic agents, The vascular receptors have no known function because acetylcholine is never released into the blood in significant quantities. Atropine, it blocks these muscarinic receptors and prevent acetylcholine from producing vasodilation. Other actions: GI tract, acetylcholine increases salivary secretion, gastric acid secretion, and it also stimulates intestinal secretions and motility. It will increase the secretions. It also enhances bronchial secretions and causes bronchoconstriction in the lungs, constriction. In GUT, it causes urination by increasing the tone of the detrusor muscle. In the eye, acetylcholine is involved in stimulation of the ciliary muscle and causing meiosis, constriction of the pupil. So we have seen decrease in BP, increased secretions, increased urination, pupil constriction for acetylcholine. About bethanycol, it is an unsubstituted carbamoyl ester. Now you have to remember somewhat medicinal chemistry because it is usually appearing in if you are appearing for exams, you have to remember these things. And its structure, it was related to acetylcholine, but what was the difference? There was an extra branching and an amine group was added in the beginning. It is not hydrolyzed by the esterification, although it is inactivated through hydrolysis. Okay, it has strong muscarinic and weak nicotinic activity. Actions: increase motility, bladder muscles are stimulated, which will produce urination. What is the therapeutic use? In neurologic treatment, bethanycol is used to stimulate bladder, particularly in postpartum or post-operative non-obstructive urinary retention. Adverse effect: bethanycol adverse effects are generalized cholinergic stimulation, sweating, salivation, flushing, decreased BP, reflex tachycardia, nausea, abdominal pain, diarrhea, bronchospasm. That's why it is not of much clinical importance. Atropine may be administered to overcome serious bronchoconstrictor and cardiovascular adverse effects. Okay, this is an antidote. You have to remember this. These are some diagrammic representation of adverse effects with cholinergic agonist. You will face diarrhea, diaphoresis, that is increased salivation, and meiosis, pupil constriction, nausea, urinary urgency due to the action over bladder muscles, detrusor muscles. And the next drug we are going to study is carbachol. Carbachol has both muscarinic and nicotinic actions. Carbachol is also an ester of carbamic acid such as bethanycol. Now actions: it has cardiovascular actions and on GI systems. It will cause the release of epinephrine from the adrenal medulla by its nicotinic actions. It is usually locally instilled into the eye and it mimics the effect of acetylcholine. So it causes pupil constriction. We can see here pilocarpine, carbachol, and atropine. All these drugs, when you treat with pilocarpine or carbachol, pupil constriction will occur. And its antidote we have also studied, atropine. Its effect will be opposite. Mydriasis, dilation of the pupil. Now therapeutic effect of carbachol: because of hypertensive and long duration of action, it is rarely used because it is not cleared. Adverse effects: few. If we are using we will use only for local effect, ophthalmologic, so its adverse effects are rarely seen. It does not penetrate into systemic circulation. Yes. studying about the receptors, muscarinic receptors. Okay, here we are shown the muscarinic receptors. These are divided into M1, M2 and M3. Now for these are muscarinic receptors, okay, this and this. It is shown that acetylcholine also binds with the muscarinic receptors, and muscarine, an alkaloid, it also binds to the muscarinic receptors. It also has a low affinity towards nicotine, okay, but the other type of receptor, that is nicotinic receptors, here nicotine binds to the receptor, acetylcholine also binds, and low affinity towards muscarine. You can see here muscarinic receptors bind to muscarine, nicotinic receptor binds to nicotine, high affinity towards these. Now first of all, we will study mechanism of acetylcholine signal transduction. How does the signal pathway occurs? M1 or M3 receptors are activated. The receptor undergoes a conformational change, which because these are, once more, these are G coupled protein receptors. We have seen in the previous lectures there are various types of receptors. This muscarinic receptor is G coupled protein. So once the receptor complex is activated, the change happens and interacts with the G protein, which activates phospholipase C. This ultimately leads to the production of second messenger. These are the second messenger, inositol 1,4,5 triphosphate, IP3, also we call it as IP3, and DAG, diacylglycerol. IP3 causes increase in calcium ions, which will interact to stimulate or inhibit and cause hyperpolarization or contraction. Now DAG activates protein kinase, an enzyme, and that phosphorylates numerous proteins within the cell. Now this was about M1 and M3. What happens in the M2 receptor? M2 subtype is a cardiac muscle, so it stimulates and inhibits adenylyl cyclase, which increases potassium. There was calcium and here it is potassium due to the cardiac. The heart responds and decrease in the rate and force of contraction. This occurs in M2 heart muscles. Now once you have understood the mechanism, M1 and M3 and M2, M1 and M3 hyperpolarization occurs or contraction. In M2, rate and force of contraction is decreased. Now agonist, we will see here agonist, muscarinic agonist. We have studied in the first, pilocarpine is a non-selective. It is not a selective, it is non-selective, and usually it is used to treat glaucoma. This is an important question you have to remember. Pilocarpine is used to treat glaucoma. Next receptors are nicotinic receptors. Now here the mechanism of action is, okay, diagram is not here, okay, we will see here. Now we have seen nicotinic receptors bind to nicotine with high affinity, also binds to acetylcholine, and a weak affinity for muscarine. Now nicotine receptors have 5 subunits, and that was muscarinic was G coupled protein receptor, and this is ligand gated ion channels. Okay, here, yes, ligand gated ion channels. Binding two molecules to acetylcholine will produce a conformational change, and it will allow the entry of sodium ions. Since it is a ligand gated ion channel, so it will allow the entry of sodium ions, and this will then result in depolarization of the effector cell. Nicotine at low concentration stimulates the receptor, whereas nicotine at high concentration blocks the receptor. You have to check it out. Now where are these present in the CNS? Adrenal medulla, autonomic ganglia, neuromuscular junction in the skeletal muscles. Those of skeletal muscles are known as NM and M, okay, for muscles, and the others are known as NN. Now the receptors of autonomic ganglia differ from those of NMJ. For example, ganglionic receptors are selectively blocked by mecalimine, whereas NMJ are blocked by atracurium. Okay, now here we can have a look at the diagram we have studied previously also. Now the site, just we have to remember the site of action. We know this is preganglionic part, this is ganglionic, and this is neuroeffector transmitter part. Okay, in the ganglionic transmitter we have acetylcholine. If we block it or increase it in the neurotransmitter effect, here epinephrine, norepinephrine, here norepinephrine, here acetylcholine and acetylcholine. Now what we have to remember here is site of action of ganglionic blockers. Ganglionic blocker will have effect here, nicotinic receptor, and for neuromuscular blockers, this nicotinic receptor in the skeletal muscle, and for anti-muscarinic drugs, the muscarinic receptor is here. Okay, in parasympathetic system it will affect here. Now we have seen the site of action. We will first have a look at the atropine drug. Now atropine chemistry, it is a tertiary amine, okay, extracted from belladonna alkaloid and high affinity for muscarinic. Okay, it prevents the binding of acetylcholine and it acts both centrally and peripherally. It is last about 4 hours duration of action. Topical administration in eye with persist for days. Muscarinic, we know it is anti-muscarinic agent. Now its actions over eye. What will happen? Dilation. Okay, mydriasis, not meiosis. For GI, it can be used as an antispasmodic agent to reduce the activity of GI tract, and atropine and scopolamine, they are most potent antispasmodic drugs. Although gastric motility is reduced, hydrochloric HCl production is not affected. Therefore, thus atropine is not effective for the treatment of ulcer. Okay, it will not affect an ulcer. But doses of atropine that reduce spasm also reduce saliva secretions. In cardiovascular system, atropine produces divergence effect depending on the dose. It is dose dependent effects. At low, slightly decrease in heart rate, the effect will result from M1 receptor, which is presynaptic. Now higher doses will cause progressive increase, okay, opposite action due to M2. This was slight decrease was due to M1 and this is M2. Now we can have a look at the dose dependent effects. At 0.5 mg, slight cardiac slowing, whereas here rapid heart rate, okay, if you increase the dose, and some dry mouth and sweating inhibition. When you increase the dose to 5 mg, rapid heart rate, marked dryness, dilation, mydriasis of the pupil, and blurring of the near vision. Increase by 10, hallucination, coma. That is toxicity. Its effect also includes secretions, dryness of mouth, it will stop saliva, xerostomia. The salivary glands are sensitive to atropine. Now, therapeutic uses. How can we use it therapeutically? Mydriatic effect on ophthalmic, antispasmodic, okay, cardiovascular, bradycardia. If you have to treat, you are required to treat bradycardia, you will inject atropine. Anti-secretory, as it causes dry mouth, it blocks secretions. Now antidote, if the toxicity occurs for organophosphate, you will use atropine as an antidote. Now its pharmacokinetics, it is partially metabolized by the liver and eliminated in urine. Half-life is 4 hours. Adverse effect, again dry mouth, blurred vision, tachycardia, urinary retention and constipation. Now low doses of cholinesterase inhibitors such as physostigmine may be used to overcome the toxicity. However, children, this drug will be dangerous for the children. Now tropicamide and cyclopentolate, these are used topically for ophthalmic solutions for mydriasis and cycloplegia. Duration of action is shorter than atropine. Tropicamide produces for 6 hours and cyclopentolate for 24 hours. Now benztropine and trihexyphenidyl. These are used with as an adjunct therapy for the treatment of anti-Parkinson disease. Now, oxybutynin and other antimuscarinic agents for overactive bladder. Actions: what does it do, how does it do? In the bladder, the receptor is M3. Now intravesical pressure is lowered and bladder capacity is increased. The frequency of the bladder contraction is thereby reduced. So what will be the actions at M3 receptors? Salivary gland, CNS, eye, all of these have M3 receptors, so the adverse effects will appear here. Now dariphenacin and solifenacin are relatively more selective. They are more selective antagonists. However, other drugs are non-selective. They will act on M1, M2 and M3. Now the therapeutic used for overactive or urinary incontinency. Oxybutynin is also used in patients with neurogenic bladder. Pharmacokinetics: available in oral dosage form, long half-life, only OD, as it has long half-life, so it is used only once daily. Now oxybutynin is also used as a transdermal patch and topical gel formulation. And all of these are hepatically metabolized by cytochrome P450, so these drugs will be affected by inducer or inhibitors. Adverse effects will dry mouth, constipation, blurred vision. Now you can see these are the adverse effects: blurred vision with antimuscarinic antagonist, blurred vision, confusion, mydriasis, constipation and urinary retention. Now here we have summary for muscarinic blockers. We'll have some here. Now the drug first we studied trihexyphenidyl and benztropine. These are used as an adjunct for Parkinson disease and management of extrapyramidal effects. Now dariphenacin, fesoterodone, oxybutynin, solifenacin, tolterodine, trospium, they are all used in urinary bladder incontinency or overactive. Cyclopentolate, tropicamide and atropine, they all are used in ophthalmology to produce mydriasis. Atropine is most important drug to study. Atropine to treat spasm in GI tract, to treat organophosphate poisoning as an antidote, to suppress respiratory secretions prior to surgery, and to treat bradycardia. Scopolamine, motion sickness, you have to remember this. Aclidinium, glycopyrrolate, ipratropium and tiotropium, these are all for COPD. Now ganglionic blocker, nicotinic, this is used for smoking cessation. Now ganglionic blockers specifically act on nicotinic receptors. Okay. Now nicotine. For ganglionic blockers we will study nicotine. This is especially used for smoking cessation. Nicotine is a poison with many undesirable actions. Without therapeutic benefit, it's not beneficial to use it. Now depending on the dose, nicotine depolarizes ganglia, first resulting in stimulation and then paralysis. These effects are complex and result with increased release of neurotransmitter. Now you can see here nicotine, what does it do to all the neurotransmitters. Nicotine, by suppressing dopamine effects of nicotine. Okay. Now by dopamine it will give pleasure, appetite suppression. Norepinephrine, appetite suppression, arousal and cognitive enhancement, memory enhancement, moods modulation, appetite suppressor, reduction of anxiety and tension at GABA receptors. Neuromuscular blocking agent. Now neuromuscular blocking agent means they block the transmission between motor nerve endings and the nicotinic receptors on the skeletal muscles. Now they possess similarities to the acetylcholine and act either as antagonist, non-depolarizing, or agonist, depolarizing. You have to remember this on NMJ. Now blockers are facilitated intubation, rapid intubation when it is needed when you have respiratory failure, endotracheal intubation, and provide complete muscle relaxation at the lower anesthetic doses. Okay, this increases the safety of anesthesia by allowing the patients to recover quickly and completely. And these are used in ICUs. Now, non-depolarizing competitive blockers. The first was curare. The development of tubocurarine, followed by cistracurium, mivacurium, pancuronium, rocuronium, and vicuronium. Now its mechanism of action. First we will understand the mechanism of action. Its mechanism is dose dependent. Now at low doses what happens? It will block acetylcholine at nicotinic receptor. Okay, nicotinic receptor, the acetylcholine is blocked. Rocuronium, it comes and binds, and the acetylcholine binding is being blocked. Now it prevents depolarization of the muscle and inhibits muscle contraction. The competitive action can be overcome by administration of cholinesterase inhibitors, physostigmine or edorphonium. It will increase the concentration of acetylcholine at neuromuscular junction. So this strategy shortens the duration of this neuromuscular blockade. In addition, low doses, the muscle responds to direct electrical stimulation from a peripheral nerve stimulator to varying degrees. Now at high doses, what happens at high doses? High doses, it will block the ion channels. This will lead to weakening of the transmission and reducing the ability of the enzyme inhibitors, cholinesterase inhibitors, which reverses the action. Now what are its actions? We have seen mechanism of action. Now what are its actions? Now due to sensitivity of blockade by competitive agent, small rapidly contracting muscle of the face and eye are most susceptible and paralyzed first, followed by finger, limb, neck, and trunk muscles. Now what is the pharmacokinetic? Two or more quaternary amines. Penetration through membranes is poor, they do not cross BBB, and cistracurium undergoes organ independent metabolism, Hoffman elimination, and verocurium and rocurium are deacylated in the liver, metabolized in the liver and changed in the bile. Mivacurium is eliminated by plasma cholinesterase. Now you can see here the pharmacokinetics. Neuromuscular blockers are minimally absorbed when given orally, so they are given IV. Vicuronium and rocuronium and metabolites appear mainly in bile. Okay, this is kinetics. Pancuronium is excreted primarily in urine. Now this is also about its characteristic features. Okay, here. Now this is the time to maximal blockade, and this is the time to recover. 2 and 40 minutes, 2 minutes and 40 minutes for atracurium. For cistracurium, 3 minutes and 90 minutes. For pancuronium, 3 minutes and 66 minutes. Time to recover 25% of maximal response. Now cistracurium spontaneously degrades in plasma. Okay, it is often used in patients with multi-system organ failure because its metabolism is independent of hepatic metabolism or renal function. Okay, if you have multi-system organ failure, it means hepatic and renal function will be affected, so we can use cistracurium in ventilation patients who are in ventilator. Pancuronium is vagolytic and increases the heart rate. Now vicuronium, succinylcholine, it is used in post-operative muscle pain, hyperkalemia, and increased IOP and intragastric pressure may occur. Drug may trigger malignant hyperthermia Now it has rapid onset of action, therefore it is used for tracheal intubation for gastric contents. Okay, now adverse effects. These are safe, minimal side effects. Drug interactions with inhibitors. Now since they are enzyme dependent, so cholinesterase inhibitors, those who inhibit the enzyme. Now neostigmine, physostigmine, pyridostigmine, and dorfonium can overcome the action of NMBs with increased doses. This can cause depolarizing block due to elevated acetylcholine. Halogenated hydrocarbon anesthetics. The other anesthetic which are halogenated hydrocarbons such as desflurane, they act to enhance neuromuscular blockade by exerting a stabilizing action at MGMG. These agents sensitize this to NMBs. Now aminoglycoside antibiotics gentamicin and tobramycin, they will inhibit acetylcholine release from cholinergic nerves by competing with calcium ions. So they will increase its blockade. Calcium channel blocker will also increase the blockade. Depolarizing agents, it means they work by depolarizing the plasma membrane of the muscle fiber, similarly as acetylcholine works. Now these are more resistant to degradation by acetylcholinesterase and more persistently depolarize the muscle fibers such as succinylcholine. This is the example we are going to study here. Now what is the mechanism of action of succinylcholine? It will attach to the receptor, nicotinic receptor, and act like acetylcholine to depolarize the junction. Now unlike acetylcholine, which is instantly destroyed by the esterase enzyme, the depolarizing agent, this succinylcholine, will persist at higher concentration in the synaptic cleft, and it will remain attached for a longer duration of time. It will provide sustained depolarization. Duration of action here, it's not dependent on the esterase enzyme, it dependent on the diffusion from motor end plate and hydrolysis by plasma cholinesterase, also called butyryl cholinesterase or pseudocholinesterase. Okay, now here genetic variants in which plasma cholinesterase levels are low or absent, they will lead to prolonged paralysis. The depolarization first causes opening of the sodium channels. Okay, it will first open the sodium channels which are associated with nicotinic receptors, which results in depolarization of the receptor. This is called phase 1. This will lead to twitching of the muscles, fasciculations. Now it is continuous binding to depolarization. Now it renders the receptor incapable of transmitting further impulses. Okay, it will render it. With time, continuous depolarization give way to gradual repolarization as sodium channel closes or is blocked. Okay, the sodium channel is blocked. This will cause resistant to depolarization, and it is flaccid paralysis phase 2. We can see here phase 1. Phase 1 is first succinylcholine enters here, it comes on the receptor, nicotine, it blocks the sodium channel. Now membrane depolarizes. Okay, membrane is depolarized, which will result in initial discharge that produces transient fasciculation, and it will follow by flaccid paralysis. Now the phase 2. Now what happens in phase 2? Membranes, it is being attached, sodium channel is blocked. Now membrane is repolarized. How? Membrane repolarizes, but receptor is desensitized to the effect of acetylcholine. Remember this, the receptor is still desensitized to the effect of acetylcholine. Now actions as compared, this is for succinylcholine, as compared with competitive blocker, the respiratory muscles are paralyzed last. Succinylcholine initially produce brief fasciculations. They may be prevented by small doses of non-depolarizing NMB. Okay, prior to succinylcholine. Therapeutic use is intubation, endotracheal intubation. Kinetics, it has brief duration of action which results from redistribution and rapid hydrolysis by the plasma enzyme. Adverse effects are hyperthermia, apnea, and hyperkalemia. Succinylcholine will produce malignant hyperthermia. Apnea, patient who are deficient in this enzyme has a typical form of enzyme that will lead to prolonged apnea due to paralysis of the diaphragm. Hyperkalemia, it will increase the potassium from intracellular stores, and it is really dangerous in burn patients and patients with massive tissue damage. Sympathomimetic drugs. Norepinephrine or epinephrine act on the receptors, on adrenergic receptors, therefore they are called adrenergic agonist. Now the adrenergic neuron, you have to have a look at here. Now adrenergic neurons release norepinephrine, okay, as a primary neurotransmitter. These neurons are found in the CNS and in the sympathetic nervous system. Now you can see here, this is the adrenal medulla, and here you can find nicotinic receptors, and these are in the now this is pre-synaptically on the neurons or post-synaptically on the neurons, okay. Epinephrine, adrenal medulla, epinephrine is released into the blood and it goes into the effector organs on adrenergic receptor. Here where there are nicotinic receptors in the sympathetic nervous system, okay, they are released norepinephrine in the ganglia and it goes on the effector organs and attached to the adrenergic receptor. These are the two sites of actions for the agonist. Now neurotransmission at adrenergic neuron. You can have a look. This is the whole mechanism of action. You should understand this. The first step is, the neurotransmitter must be synthesized and released, okay. How it is synthesized? Tyrosine and sodium ion, these two enter. Now hydroxylation of tyrosine is this hydroxylation here. It is a rate limiting step. Now next, what happens? Uptake into the storage vesicles. It converts into dopa is the precursor of dopamine, and it converts into dopamine. Now dopamine is uptake in the storage vesicles. Now dopamine enters into a vesicle, and here when it enters into the vesicle, it gets converted into norepinephrine, okay. Norepinephrine is protected from degradation, that's why it is stored in the vesicle, and then it is transported into the vesicle. With this transport in the vesicle, if you inhibit the transport, the system will be blocked. So this is inhibited by reserpine, antihypertensive drug, okay. Now release of neurotransmitter. Third step, one, its synthesis first, second, uptake in the storage vesicles. Now its release. Influx of calcium ion. This step, influx of the calcium ion, causes the fusion of the vesicle within the cell membrane in the process called exocytosis. Exo means out, cyto. Now this release is blocked by guanethidine. You can have a look here. These are the examples of the drugs which act here. These are the site of actions. Now as norepinephrine is released, it binds to the receptor in the effector cells. After binding, it activates the receptor complex, and then removal of norepinephrine released. Norepinephrine is rapidly taken into the neuron. This released is rapidly taken into the neuron, and reuptake is inhibited by SNRIs. serotonin and norepinephrine reuptake inhibitors, SNRIs and cocaine and imipramine. These all inhibit the reuptake of norepinephrine. Here they will work, these drugs. Then sixth is metabolism. Norepinephrine is methylated by COMT. This is maybe carboxymethyltransferase, and it is oxidized by MAO. Now when it see catechol O methyltransferase, okay, this enzyme and MAO, these two, they metabolize the norepinephrine, and when it is metabolized it converts into inactive metabolites and it is eliminated in the urine. This is the whole cycle of norepinephrine adrenergic system, sympathomimetic system. We will, if you understand this, it will be easy to understand the mechanism of actions of the drugs we are going to study, direct inhibiting or indirect inhibiting. Now we are continuing adrenergic receptors, also called as adrenoceptors. Now two main families of receptors are there, alpha and beta. Alpha and beta are also further divided, alpha 1, alpha 2, beta 1, beta 2 and beta 3. Now first we are going to study about alpha receptors. They respond to synthetic agonist isoproterenol. They are responsive to the naturally occurring catecholamines, epinephrine and norepinephrine. Okay, the potency is epinephrine is more potent towards the receptor than norepinephrine, and isoproterenol is less. Now you can see here, this is defined as affinity for alpha receptors. Okay, two type of adrenoceptors we have studied, alpha and beta. Alpha adrenoceptors, the affinity towards the alpha receptor lower to high, the highest epinephrine, then norepinephrine, and the lowest is isoproterenol. For beta adrenoceptors, the affinity for beta receptor highest isoproterenol, then epinephrine, and the least is norepinephrine. For isoproterenol, it is opposite for both receptors. Now we will see here alpha 1 receptor, the subtype. These are postsynaptic. Okay, they will mediate classic effects such as constriction of smooth muscle. Now activation of alpha 1 will initiate G protein activation of phospholipase C, which will result in second messenger inositol 1,4,5 triphosphate, IP3, just remember IP3, and DAG. Okay, IP3 will initiate the release of calcium from endoplasmic reticulum into the cytosol, and DAG turns into the other proteins within the cell. Now you can see in this diagram, it's better clear explanation. Alpha 2 receptors, this is norepinephrine in synaptic vesicles and exocytosis. Norepinephrine is released, it attaches to the receptor. This is alpha 1. Okay, this is alpha 2. Alpha 2 activation of the receptor decreases the production of CAMP, leading to an inhibition of further release of norepinephrine. It inhibits this process, production of CAMP, and therefore further release of norepinephrine is decreased. Next, alpha 1 receptor. Alpha 1 receptor activation of the receptor will increase the production of DAG and IP3, as we have studied earlier, DAG and IP3, and these will increase the intercellular calcium ions. Now you can see here alpha 2 receptors, they are located on sympathetic presynaptic nerve endings, as we have studied up in the above diagram. When it is stimulated, it gives an inhibition feedback mechanism for inhibition to further stop the release of norepinephrine, and then alpha 2 receptors found on presynaptic parasympathetic neurons, norepinephrine released from presynaptic sympathetic neuron can diffuse to and interact with the receptors and inhibit acetylcholine release. Now there is another mechanism to modulate autonomic activity in the given area. In contrast to alpha-1 receptor, the effects of binding of at alpha-2 are mediated by inhibition of adenylyl cyclase, and they fall in the levels of intracellular CMP. There is also further subdivisions: alpha-1A, alpha-1B, alpha-1C, alpha-1D, alpha-2A, B and C. But it is not necessary to understand in deep. You can just have a look. For example, tamsulosin is selective alpha-1A, and it is used in benign prostatic hyperplasia. As it is such selective, so it gives very low side effects, and you have to remember this drug for the treatment of benign prostatic hyperplasia, BPH, commonly found in elderly men. The sympathomimetic drugs, sympathomimetic system. Now we are talking about beta adrenoceptors. This response is totally different from alpha receptors, okay, and are characterized by strong. We have studied the stronger affinity was isoproterenol, then epinephrine, norepinephrine. These are divided into beta 1, 2 and 3, okay. Now beta 1 have equal affinities for both epinephrine and norepinephrine. Beta 2 have higher for epinephrine. A tissue with more beta 2 receptors, they are particularly responsive for circulating epinephrine, okay, which is released by adrenal medulla. Now binding to neurotransmitter, and at any of these three types, beta 1 or 2 or 3, it will result. What is the mechanism of activation of adenylyl cyclase, and it will increase the concentration of CMP within the cell. Now distribution. Tissue such as vasculature of skeletal muscle, okay, skeletal muscle have alpha 1 and beta 2. Beta 2 are predominant there. Other tissues have only one. For example, heart, it has predominantly beta 1. Now the distribution of receptors, we can easily recognize its effect. It is useful to organize a response according to the receptor type. The type, if you know the type, and you know the drug acts on which type of receptor, it will be easy to identify the physiological responses. Now, such as alpha 1 receptor produces vasoconstriction, skin and abdominal viscera, and increased TPR, total peripheral resistance, and so increases blood pressure, okay, alpha 1. Beta 1 stimulation will cause cardiac stimulation, it will increase in heart rate. Beta 2 causes vasodilation in the skeletal muscle. Beta 3 are involved in lipolysis along with beta 1, and also have effect on the dorsal muscle of the bladder. We can also have a look at this table, it's very important. Now adrenoceptors, 4 major types: alpha 1, alpha 2, beta 1 and beta 2. Alpha 1, vasoconstriction, increase peripheral resistance, thus increases BP, mydriasis, dilation of pupil size, increase closure of internal sphincter in the bladder, okay, it acts in the bladder, eyes and vessels, increasing BP. Alpha 2 inhibits the release of norepinephrine, inhibits the release of acetylcholine, inhibits the release of insulin. Beta 1, it acts on heart, cardiac muscles, tachycardia, increases the heart rate and increases lipolysis, we have also seen, and increase myocardial contractility and increase the release of renin. Beta 2, it causes the opposite action of alpha 1, vasodilation. Now opposite vasodilation, increase peripheral resistance, here it will be decreased peripheral resistance, and thus it has bronchodilation effect, therefore it is used in asthma. Increased muscle and liver glycogenolysis, increased release of glucagon, here inhibition of insulin, and here increased release of glucagon. Relax uterine smooth muscles. These are the major effects. If you remember these effects, it will be very easy to recognize the drugs and their physiological response and the reason behind them. Now, desensitization of receptor, we have also previously studied prolonged exposure. Desensitization is always related to prolonged exposure. Here, when the receptors are prolonged exposed to catecholamines, they will reduce the responsiveness. The phenomena is first sequestration of the receptors, so they are unavailable for the interaction. Then second one mechanism is downregulation, disappearance of the receptors. Third is inability to couple with G protein because the receptor has been phosphorylated on the side of the plasmic site. Characteristic of adrenergic agonist. Basically, its chemistry. They are the derivatives of beta phenylethylamine. Okay. Substitution on the benzene ring or ethylamine site will produce a variety of compounds. Okay, these two substitutions will occur, and it will differentiate between alpha and beta receptors to penetrate the CNS. Two important structural features you have to remember: number, location of OH substitutions on the benzene ring, nature of the substituent on the amino nitrogen. We can have a look at here. Sorry. Now we have checked this phenylepinephrine. These all, as we have studied here, these all are beta phenylethylamine. Okay, now this is beta phenyl, this is the phenyl group, and this is at beta carbon ethyl, and this is amine. So all of them have these structures. Epinephrine, you can see the OH group phenyl is missing here. Norepinephrine, you have an extra H substituent, and for epinephrine you have an methyl group. For isoproterenol you have an extra ethyl group. So it increases the beta receptors affinity to, as you add an methyl group on the nitrogen atom, it will increase its size and increase in the affinity. The last one is dopamine, and you can see there are two OH molecules here on the benzene ring, and its structure is relatively small to cross the BBB. Now catecholamines, sympathomimetic amines, the chemistry for catecholamines is they have 3,4-dihydroxybenzene group, and this group was present in epinephrine and norepinephrine, isoproterenol and dopamine. These are called catecholamines, these four drugs. The compounds share following properties due to the same structural group. The properties they share is high potency and directly activate alpha or beta receptors, and they are rapid in activation. Catecholamines are metabolized by COMT postsynaptically, we have studied earlier, and by MAO. Now COMT and MAO in the gut wall and by MAO in the liver. In the gut wall, in the liver, thus they have only brief period of action when they are given IV, and they are inactivated when they are given orally because of gut wall. Poor penetration of CNS. They do not penetrate. Most catecholamines have some clinical effects, as they are the reason behind is they are polar, and most catecholamines have some clinical effect, anxiety, tremor, headache, that are attributable to the action on CNS. Non-catecholamines, they just differ, lacking the catechol hydroxyl groups, and so they have now this makes them polar, and it will make this less polar, so it will have longer half-life. They will not be inactivated by COMT, and these include phenylephrine, ephedrine, and amphetamine. These agents are poor substrates for MAO. Thus, they have a prolonged duration of action and increased lipid solubility, therefore, they will cross the CNS BBB. Now, substitutions of the amine nitrogen. The nature of the substituent will determine the beta selectivity. For example, epinephrine with a methyl substituent on amine nitrogen is more potent at beta receptors than norepinephrine, which is not substituted with any methyl group. Isoproterenol has an isopropyl substituent on amine nitrogen, and it will have strong beta agonist with little alpha activity. And now we are continuing the mechanism of action for the sympathomimetic drugs. There are basically three types: indirect acting, mixed acting, and direct acting. Now, indirect acting drug will enhance the release of norepinephrine from the vesicle. It will directly act here. These drugs, when they directly act on beta receptors, they will produce similar to those that occur following stimulation of sympathetic nerves or release of epinephrine from the adrenal medulla. For this examples here, direct one, we will get example epinephrine, norepinephrine, isoproterenol, dopamine, and phenylephrine. Indirect will act here. They are indirectly enhancing the release of norepinephrine. Mixed means they will act at both the sides, directly and indirectly. Direct means directly the drug will activate the receptor here. Directly the drug will come and stimulate this and act as if it is the neurotransmitter. Now we will have a look at the direct acting drug which will act on the receptor postsynaptically. Epinephrine is one of the 4 catecholamines. Now the epinephrine, norepinephrine, and dopamine, these are all naturally occurring. Dopamine is a synthetic catecholamine. Now these are stored in chromaffin cells along with norepinephrine. When the adrenal medulla is stimulated, 80% of epinephrine and 20% of norepinephrine are released into the circulation. Epinephrine will interact with both alpha and beta receptors. Low doses, it will cause vasodilation. High doses, it will cause vasoconstriction, because at low doses it will affect beta receptors, and at high doses it will affect alpha receptors. First, its action on cardiovascular system. The major effect on the cardiovascular system, it will increase the contractility of myocardium. It is positive inotropic drug, beta 1, and it will increase the rate of contraction, positive chronotropic. It has both. Epinephrine is positive inotropic as well as positive chronotropic. Epinephrine will activate beta 1 receptors on the kidney, and it will cause renin release. Renin, as you know, it is an enzyme which is involved in the production of angiotensin II, potent vasoconstrictor. Epinephrine will constrict the arterioles in the skin, mucous membrane, and viscera. It will dilate the vessels which are going to the liver and skeletal muscles by its beta 2 effect. These all effects, when are combined, will decrease in the renal blood flow, therefore increase in the systolic BP, slight decrease in the diastolic due to beta 2 receptor activation. Cardiovascular effects of IV infusion. When epinephrine is given at low doses, IV infusion, pulse, BP, and peripheral resistance. Epinephrine will increase the rate and force of cardiac contraction. Therefore, pulse rate will increase. And BP, systolic BP is increased, diastolic is little bit decreased. For peripheral resistance, it will decrease the peripheral resistance. These are the cardiovascular effects combined when you give epinephrine IV. The other effects, hyperglycemia. It will cause hyperglycemia as it will increase glycogenolysis, breakdown of glycogen in the liver, beta 2 effect, and it will increase the release of glucagon in beta 2 effect, decrease the release of insulin by alpha 2 effect. Lipolysis, acting on beta receptors of adipose tissue, it will increase CAMP and stimulate the hormone sensitive lipase which hydrolyzes TGs to free fatty acids and glycerol. Due to its actions on respiration lungs, it is primarily used in the emergency treatment of respiratory conditions. Anaphylactic shock. Epinephrine is the drug of choice. It can be life-saving in many settings. Anaphylactic shock, the drug is the first choice for type 1 hypersensitivity reactions. Cardiac arrest. It is also used in cardiac arrest to restore the cardiac rhythm. For local anesthesia, it will, in low concentrations, epinephrine increases the duration of local anesthesia by producing vasoconstriction and at the site of injection. Intraocular surgery. It is used in the induction and maintenance of mydriasis. Now pharmacokinetics. You can see from here. It is given IM, IV, as subcutaneously. Its metabolites will occur in the urine, poor penetration due to its structure into the CNS, and it is also given in inhalation, not oral, due to its degradation in the gut. Adverse effect, as it can produce CNS adverse effect, anxiety, fear, tension, headache, and tremor. It can trigger cardiac arrhythmias if the patient is receiving digoxin. This is the drug interaction. Epinephrine will also induce pulmonary edema due to increased overload by vasoconstrictive properties. For hyperthyroidism patient, adrenergic receptor in the vasculature will lead an enhanced response to epinephrine, and the dose must be adjusted. It must be reduced in those individuals. Inhalation anesthetic to sensitize the heart to effects of epinephrine, which will lead to tachycardia. We are going to continue adrenergic drugs. Now here, this is a summary table for therapeutic uses of these drugs. Now first we will study the catecholamines. Catecholamines were 5 epinephrine, norepinephrine, isoproterenol, dopamine, and dobutamine. Epinephrine acts on both alpha and beta. Norepinephrine, except beta 2, it acts on all. Isoproterenol is beta non-selective. Dopamine is alpha 1 and beta 1 plus dopaminergic, D receptor. Dobutamine is only beta 1 selective. Anaphylactic shock, cardiac arrest, local anesthetic to increase the duration of action. Norepinephrine, treatment of shock. Isoproterenol as in cardiac stimulant. Dopamine, treatment of shock, treatment of CHF and high BP. Dopamine, treatment of acute heart failure. These catecholamines have rapid onset of action, brief duration of action as they metabolize rapidly. So in GIT, therefore they are also not administered orally and they do not enter BBB. Versus with non-catecholamines, they have longer duration of action and they can be administered orally. Oxymetazoline, phenylephrine, clonidine. These are alpha. Oxymetazoline alpha 1. So it is used for nasal decongestion and eye redness. Phenylephrine alpha 1, also nasal decongestion, high BP and paroxysmal supraventricular tachycardia. Clonidine acts on alpha 2, treatment of hypertension. Albuterol, metoprolol, terbutaline acts on beta 2, treatment of bronchospasm, short acting. Alphomoterol, formoterol, indacaterol, salmeterol, they are acting on beta 2, same as this treatment bronchospasm, but the difference is they are short acting and these are long acting. Now amphetamine acts on non-selectively alpha, beta and in CNS. So it is used in CNS treatment of children, ADHD and for appetite control. Ephedrine and pseudoephedrine, they are also non-selective and CNS and used in high blood pressure and as a nasal decongestant.